assessment does not mean focused airway examination. It also includes the history and general physical examination along with the local airway examination. So when we talk about airway assessment, that doesn't mean कि आप directly मुंह खोल दोगे और उसकी neck circumference और neck extension, flexion ये सब देखने लग जाओगे. No, it begins with the history. Then go on to the general physical examination. Now these two things will tell you whether there's some difficulty anticipated or not. Now based on that anticipation, the airway, difficult airway is classified as anticipated or unanticipated. What ultimately will affect is the management. The DAS, Difficult Airway Society, and ASA, Difficult Airway Algorithms. There are two algorithms which tell you how to approach a patient with anticipated difficult airway or unanticipated difficult airway. You can see the DAS guidelines on your screen. Awake intubation in anticipated difficult airway in critically ill patients, in cervical spine injury or obstetric patients, then pediatric patients, and extubation guidelines, then for unanticipated airway and hematoma. Similar to the DAS guidelines, there are American Society of Anesthesiology guidelines for difficult airway. You can see the screenshots on your screen that for adult and pediatric difficult airway, they have given their own algorithms. This is the ultimate aim of management. Now, let's begin with the history part and the examination part. Let's begin with the line of sight examination. What does that mean? Let me show you. The Airway Management Foundation gave the approach called line of sight, which was a three-step approach. It is very obvious that a difficult airway, if it is anticipated at one location, suppose it is a small hospital and it doesn't have instruments which can deal with that difficult airway. Now, at that institute, that difficult airway may be very difficult to handle. But suppose if the same patient goes to a tertiary care center or the center where the instruments for difficult airway are present, like you have still at Buji, they have your video laryngoscopes or your provision for awake fiber optic intubation. So again, suddenly the difficulty will change into comparatively easier way of handling the airway. That is how this AMF gave the three-step approach, that it is not only the patient factors, which includes the history, general physical examination, airway examination, or even the airway ultrasound. But it also depends on the non-patient factors, that is, the resources, the surgical equipments, and the airway manager's mindset. That is, if the airway manager is a first year, or if it is an airway manager is a experienced consultant. So there's a difference between these two. And based on these patient and non-patient factors, the factors are assimilated into either available, difficult, or impossible airway. In difficult airway, that means it is still optimizable and you can very well manage the difficulty. But in impossible airway, it is the non-optimizable airway. Now let's focus on the points which you have to ask in history of the patient to find if there can be some anticipated difficulty. Let's focus on the history part. In the history, if you have to see what is the mental status, because that will affect your consent taking and the cooperation of the patient. Suppose the airway is difficult and you want to attempt a awake fiber optic intubation. The patient is not cooperating, or if the patient is suppose a minor, though he will not be able to cooperate and also not able to give consent if he's not in his senses. So that airway suddenly becomes too difficult to handle. Then snoring. As you know that obstructive sleep apnea is a predictor of difficult bag mask ventilation, because the pharyngeal muscles, as soon as you induce the case and the pharyngeal muscle tone gets decreased, it will obstruct the airway and there will be no airflow. That will lead to difficult bag mask ventilation. Then we come on to the previous airway event. Suppose a patient already had a history of difficult bag mask ventilation, so you should actually document it for further surgeries because that difficulty in the previous event can be repeated in the next one. So you have to uh, correlate what happened in the last anesthesia that might replicate in the next one as well. Then comes on to the supraglottic, glottic or subglottic obstruction. If it is a non-obstruction at any place in the airway from supraglottic or glottic or the subglottic part, that means you won't be able to bag mask. Even if you put a supraglottic airway device, suppose subglottic obstruction will not be able to deliver the air. Again, if it is subglottic, suppose it is a large thyroid mass, it and there's a like subglottic stenosis or the tracheal stenosis. So even if you want to put a tube of a normal adequate caliber size, suppose it is a 7 mm internal diameter tube, but there is an obstruction in the trachea and it won't pass. Even if it has passed the vocal cords, there's obstruction is much below the vocal cords, so there'll be difficult intubation as well. So based on where the obstruction is, you have may have a difficulty in either of the three. Then, if there is a history of neck irradiation, that is, there may be fibrosis in the neck. That fibrosis will lead to structure formation or obstruction. That will again lead to difficult bag mask ventilation and why difficult laryngoscopy? Because of the irradiation, there is fibrosis. So the compliance of the submandibular space gets reduced. So you won't be able to manipulate your laryngoscope well. There will be difficulty laryngoscopy. There will be difficult CL grades. There will be CL grade 3 or 4 just because the neck has been irradiated. And because of the fibrosis, the cricothyroidotomy or the tracheostomy will again be hampered because there is fibrosis over there. So the surgical access is again restricted. So that is the importance of asking neck irradiation. Most like if it is a tubercular case or a thyroid case or a laryngeal carcinoma case, wherever or maybe a neck dissection because of some reason, there you have to ask for irradiation, the surgery history of radiation. Again, tobacco or gutka chewer, they will lead to submucous fibrosis. So there will be much less space in the oral cavity. So the supraglottic airway device won't be able to get inserted into the airway. And because of the fibrosis, submucous fibrosis, laryngoscopy again is difficult. In the cervical spine trauma, or a surgery on the spine. Suppose there was some trauma and there was enterolisthesis and they have put a plate in your cervical spine. So ultimately the cervical spine mobility is hampered. So you won't be able to put the patient into the sniffing position, the usual extension that we do in laryngoscopy. That won't be able to be achieved. So laryngoscopy is going to be difficult. And the last one being diabetes, ankylosing spondylitis, rheumatoid arthritis. These are the diseases which affect multiple joints. These are the disorders where multiple joints are hampered. So that means even cervical joint, even atlanto-occipital joint, or uh, much severe, your in rheumatoid arthritis, your laryngeal joints, that is arytenoid joints, cricoarytenoid joint, cricothyroid joint, even they are calcified. Even they are their mobility is restricted. So that is how you have difficult bag mask ventilation and difficult laryngoscopy because if there's reduced extension in these, so there'll be difficulty in positioning the patient. So there will be difficult laryngoscopy. These are the points you can see that only solely based on history, you can see that there may be possibility of that particular specific uh, bag mask, supraglottic airway device, or laryngoscopy or intubation. Then we come on to the focused general examination. This does not include your local airway examination. This is just the general examination. So the elderly patients they have, mostly they are edentulous and they have reduced buccal pad of fat. So there is leakage around the supraglottic airway device and the bag mask ventilation. Then in the gender, we have male, mostly because of their beard they have. There's difficulty in the bag mask ventilation. Less commonly the supraglottic airway device. Then BMI, if it is the patient is obese, again that we have asked in history, this history of obstructive sleep apnea. That will lead to difficult bag mask ventilation, difficult laryngoscopy because of large, thick neck circumference is too much, so you won't be able to position the patient. There will be difficult CL grades. And again, because of the fat that is deposited in the neck, you won't be able to surgically access the patient. Then in the gait, if the patient is moving very slowly because of pain in the knees or the hip, that means the joints have been involved. So there are diseases like rheumatoid arthritis where the gait is involved. You can see that even cervical spine may be involved. So based on the stiff gait, you can assess for laryngoscopy difficulty. Then change in voice because of involvement of vocal cords in the rheumatoid arthritis, you have involvement of the joints of larynx, so that is change in voice. There will be difficulty in these things. Then in pregnant women, usually they have airway edema, so they are much friable airway mucosa, and the CL grade usually decreases or increases by 1. That means if a normal female had a CL grade of 1, in pregnancy the CL grade may deteriorate to CL grade of 2. So that will lead to difficult laryngoscopy and intubation. And then we come on to the prayer sign. So there are two signs that usually we can see in prayer sign and palm print sign. You can see on the screen that in the prayer sign we ask the patient to make a fist, like make join the hands like this. If the patient is unable to uh, approximate both the hands, that means the joints are involved, and there may be involvement of cervical joint also. That is how you see check for the difficult laryngoscopy. Similarly, the palm print sign. Next part, we'll see what all specific examination, that is the line of sight examination that we do to assess the airway in every